Hello everyone. Welcome to this presentation on the APGAR score, a cornerstone of neonatal care. Developed to provide a quick, standardized evaluation of a newborn's condition at birth, the APGAR helps clinicians assess the need for immediate intervention. Today we will explore its history, components, scoring, interpretation, clinical role, limitations, and practical applications. As family medicine professionals, understanding the APGAR provide us to support high-risk deliveries and educate our teams effectively. Let's begin with its origins. Our story starts in the 1950s when anesthesiology was advancing but neonatal assessments were inconsistent. Dr. Virginia APGAR, an anesthesiologist at Columbia University, recognized the need for a simple tool to evaluate newborns, especially those affected by maternal anesthesia. In 1952, she introduced the APGAR score, named after her but cleverly standing for appearance, pulse, grimace, activity, and respiration. Before APGAR, evolution varied widely, leading to delays in resuscitation. Her system standardized care, reducing infant mortality in the delivery room. Over time, it evolved with refinements such as incorporating timing protocols and remains a global standard today. Over decades, it's evolved. The American Academy of Pediatrics formalized its use in 1965, and by the 1980s, serial scoring was recommended. Today, it is integrated into global guidelines like those from the World Health Organization, proving its adaptability from high-tech NICUs to rural clinics. The beauty of APGAR lies in its five simple observable components, each score 0, 1 or 2 based on the newborn's response, totaling a maximum of 10. Remember the mnemonic APGAR to keep them straight during a busy delivery. Starting with appearance or skin color, score 0 for pale or blue everywhere indicating poor oxygenation, 1 for pink body but blue extremities, and 2 for fully pink showing good perfusion. In preterm infants, pallor might signal anemia or shock. Pulse, the heart rate, 0 if absent, 1 for under 100 beats per minute, 2 for over 100, a reassuring fetal to neonatal adaptation. Use auscultation or palpation, umbilical cord if needed. Grimace, assessing reflex irritability, stimulate the sole or nasal area, 0 for no response, 1 for weak grimace or cry, 2 for vigorous cry, cough or sneeze, reflecting intake neurological function. Activity, muscle tone, 0 for completely limp means hypotonia, possibly from depressions, 1 for slight flexion of hips and knees, and 2 for flex limbs with spontaneous movements like kicking. Finally, respiration, 0 for apneic means no effort, gasping at best, 1 for slow, irregular breaths or weak cry, 2 for lusty, regular crying with good chest expansion. These elements collectively goes oxygenation, circulation and neurological status. Think of it as a mini neurologic exam in 60 seconds. Executing the APGAR is deceptively simple but requires practice to avoid bias. Ideally, one observer scores all components simultaneously without interrupting care. For each, it is binary in a way, 0 for absent, completely abnormal, needs intervention, 1 for intermediate, monitor closely, and 2 for normal or vigorous, means reassuring, tally quickly. For example, a crying pink baby with a strong pulse might scores 9 to 10 right away. Avoid overthinking, it is observational, not a diagnostic. Timing is non-negotiable per neonatal resuscitation program guidelines. The 1 minute score captures the initial adaptation to air, cord clamping, and thermal stress. Think of it as the shock of birth readout. The 5 minute score reflects recovery or response to initial steps like stimulation or oxygen. If either is below 7 or if the baby isn't vigorous, continue scoring at 10, 15, or 20 minutes up to 30 if intubated. In a real scenario like meconium aspiration, that 20-minute check might confirm if ventilation is turning things around. Interpreting scores guides immediate actions. A total of 7 to 10 is reassuring, signaling a vigorous newborn with good adaptation, no routine intervention needed beyond standard care. Score of 4 to 6 indicate moderate depression, often due to asphyxia or sedation. These infants require stimulation, oxygen, or basic resuscitation like drying and warming. Score of 0 to 3 denotes severe depression, a red flag for hypoxia or other distress, prompt advanced measures such as positive pressure ventilation or intubation per NRP guidelines. Clinically, low scores correlate with higher risk of complications like seizures or acidosis, but always contextualized with gestational age and maternal factors. The 5-minute score is more predictive of outcomes than the initial one. The APGAR's true value lies in its role as an immediate indicator of neonatal vitality, helping prioritize resuscitation in the golden minute after birth. It facilitates team coordination, ensuring timely intervention that can prevent long-term issues like hypoxic ischemic encephalopathy. Yet, its limitations are crucial to teach. The APGAR doesn't predict long-term neurological outcomes. Many low-score infants recover fully with prompt care, while some high-scores ones may later show deficits. Factors like prematurity, maternal medications, or gestational diabetes can artificially lower scores, so integrate it with umbilical cord gases or other assessments. In essence, it is the starting point, not the whole story. In high risk scenarios like shoulder dystocia, breech, or IUGR, the APGAR adapts well but demands nuance. For premise, lower thresholds for normal and integrate with tools like the Silverman score for respiratory distress. In resource poor settings, its no equipment simplicity signs. WHO data shows it reduces mortality by 20% in low income countries when trained midwives use it, though inter observer variability highlights training needs. Controversies arise from misinterpretation. It sometimes over-rely on for legal or prognostic purposes, despite evidence showing poor correlation with IQ or cerebral palsy. The extended APGAR addresses this by including serial scoring up to 30 minutes, offering better insights into recovery trajectories. As clinician, we must use it judiciously, avoiding undue parental anxiety from isolated low scores. For practical use, embed the APGAR into your delivery protocols, assign a dedicated scorer, obtain the pediatrician or midwife, and integrate it with NRP algorithms. Communicate clearly, share scores with the team for handoffs and with parents in reassuring terms like your baby is breathing well and responding to touch. Documentation is key. Record each component score, total, and timing in the chart, noting any intervention. This supports continuity of care and medico legal protection. In family medicine, teaching this to residents ensure consistent applications across settings. To summary, the APGAR score endures as an elegant, equitable tool. Dr. APGAR's legacy in 5 letters, empowering us to act swiftly in neonatal crisis while humbling us with its boundaries. Key takeaways: grasp the components and mnemonic for quick recall, time scores to guide resuscitation, interpret ranges with clinical context, mindful of co founders, apply judiciously in high risk or low resource care, and document, communicate to foster team trust. In family medicine, it bridges education and practice, improving outcomes for the teeniest patients. Thank you guys. I am open to questions or cases from your experience. Reach me via comments or DM me on Instagram for resources or collaboration. And please like, share, and subscribe to the Docsaab's Diary.